Hello everyone, my name is Rene Tovar, and today I would like to take this opportunity to talk to you about study blinding. In my presentation, I'll focus on three major issues, starting with some definitions that we need to understand, then who can be blinded, and the consequences of unblinding. So now please welcome, and without any further delay, let's get into it. I have no financial conflict of interest to disclose. Okay, so let me start by saying a few words about blinding and allocation concealment, which do not mean the same. First of all, blinding or masking is the methodological principle of concealing group allocation from subjects and study staff after randomization. This concept should not be confused with allocation concealment, which refers to hiding group allocation during the randomization process, preventing selection bias. Now, allocation concealment protects the allocation sequence before and until assignment, and blinding protects the sequence from then on. So, as we can see in our graphic, allocation concealment prevents selection bias, whereas blinding minimizes performance and detection bias. Please let me give you an example so we can understand those concepts. So, let's imagine we are in a radiology office and we are doing this study where participants are enrolling. And in order to make this simple, we are going to have a sign-up sheet on the wall where we are going to put women into the study as they appear. So let's imagine we have a number on the side and Chloe comes in and we put her name on the list and she's in the mammography group. Then Olivia comes in and we put her name on the list and she's in the no mammography group. The next patient comes in and she's in the mammography group. And then Emily comes in and we see that Emily is going to go into the no mammography group. But then we stop for a minute, we say, wait a minute, for whatever reason we want Emily to be in the mammography group. So we simply take her up the no mammography section and we just move her down into the slot where she's going to receive mammography. And she gets enrolled in the study and nobody knows that ever happened. And it's just part of the process, and this is where the risk can occur when we don't conceal allocation. We have this possibility of selecting, choosing people and putting them into one group in the study or another. In other words, selection bias. Now, let's move on to our second issue, which is who can be blinded. So, when we conduct a clinical trial, there are a lot of people who are involved in designing, conducting, and analyzing the clinical trial. And so, everyone involved in the clinical trial may have some preconceived ideas about the product or treatment being studied. So, for instance, the principal investigator of the trial may believe the experimental treatment is effective. And such preconceptions may cause intentional or unintentional influence on how study personnel conduct their parts of the trial, which eventually may cause influence on how the final data are collected or analyzed and what the final results might be. And so, as you can see on the screen, almost everyone can be blinded, from the ones who receive the trial intervention to the ones who write a paper with trial results. So let's look over some blinding terminology. Generally speaking, there are three types of blinding, even though some papers might refer to a fourth one as quadruple blind. Okay, so before starting to talk about types of blinding, we should know that an open-label trial is when both patient and investigator know the randomized treatment. For example, surgery versus cardiac device. For obvious reasons, you will be collecting information about the surgery and the device, and therefore everyone will eventually know. Now, single-blind trial is when the physician knows, but the patient does not know the randomized treatment the patient is receiving. Usually, when we talk about single-blind trial, the group that is blinded is the patient's group. We will often see this in trials comparing two drug-eluting cardiac stents, because for obvious reasons, the interventional cardiologist will eventually be unblinded while performing the procedure. Now, double-blind trial is when neither the study center physician, who is either treating or evaluating the patient or both, nor the patient themselves know the treatment the patient is receiving. In this way, at least the patient theoretically won't be underreporting outcomes and the physician won't treat patients differently regardless of treatment group. And that is because the physician does not know what treating patients, and this again minimizes, if not eliminates, bias. Of course, in such a case, patients must sign an informed consent form. And triple-blind trial, actually there is no real consistent definition, but some would say that the ones who are blinded are the investigators, the patients, and the statisticians. Now, I'd like to put the situation into some kind of perspective. So let's suppose we have a patient who knows they received placebo and due to that may subconsciously be less enthusiastic about participating in the trial. In other words, an intentional bias. And such a patient may decide to prematurely withdraw from the trial because they were receiving placebo. And now you have missing data, which occurs when the value of the variables of interest are not measured or recorded for all subjects in the sample. Such a patient may underreport the benefit of subjective efficacy outcomes like pain score or quality of life just because they are on a placebo. They feel well when in fact they are not getting an improvement. Another example is on the physician side or physician who's evaluating a subject in a clinical trial and knows that the subject received experimental treatment. Well, again, even subconsciously, they might be more probing when evaluating the patient for adverse events. There are other consequences of unblinding such as loss of placebo effect, when the effect of the treatment, ritual, and patient-healthcare provider interaction is lost. Response or self-report bias, which is the tendency for subjects to report or not the efficacy or side effect. Non-compliance, meaning the tendency not to follow the protocol. And co-intervention, which is the tendency to seek adjunct treatment and/or systematic differences in basic care. So, to sum up, unblinding study personnel could lead to perception of bias being introduced in study conduct, data collection, or analysis. Which is why blinding along with randomization protects patients and researchers from contaminated findings and decreases the subjectivity of clinical trials. And of course, besides blinding, there are other challenges to bear in mind such as manufacturing to make the different study treatments identical in appearance, touch, smell, etc. Lastly, there is a saying that goes, some is better than none, meaning that if blinding of all individuals is not possible, an effort should be made to blind as many parties as possible. That brings me to the end of my presentation. I hope you found this video useful. Thank you for watching, and let's keep learning.